The chaos of the trauma bay has just subsided. A patient lies on the table after a massive blunt force impact, their airway secure, breathing steady, and circulation ostensibly restored. Advanced trauma life support protocols dictate looking for the deadly dozen thoracic injuries. The first half, the lethal 6, announce themselves immediately. They cause rapid, loud physiological collapse that must be caught and treated during the initial primary survey. Clearing that initial assessment can create a false sense of security. Beneath the surface, the initial kinetic energy transfer has initiated a subtle, creeping decompensation. These are the hidden 6. This secondary tier of lethal thoracic injuries rarely presents with obvious external bleeding or tension physiology, allowing them to evade the initial visual and tactile exams. Uncovering them requires a deliberate shift in strategy. Clinicians must move past the primary physical exam and utilize deliberate, systemic diagnostic imaging to map exactly where the kinetic energy damaged internal structures. Stability in the trauma bay is a temporary state. Preventing late-stage shock requires identifying these covert anatomical disruptions before the patient's physiological reserves are exhausted. The central vascular structures of the thorax are suspended within the chest cavity, making them highly vulnerable to sudden deceleration and blunt anterior force. In a blunt aortic injury, high-energy deceleration, like a head-on collision, causes massive shearing forces. The descending aorta is relatively fixed, while the aortic arch is noble, concentrating the tearing stress precisely at the aortic isthmus. The clinical warning signs of a partial tear are subtle. A clinician might note an unexplained difference in blood pressure between the left and right arms, a new systolic murmur, or sudden paraplegia resulting from spinal cord ischemia. The initial screening red flags often appear on a chest X-ray. The key indicators are a loss of the aortic knob outline and a mediastinum widened beyond the critical 8 cm threshold. To accurately locate the exact position and extent of the tear, CT angiography of the chest serves as the gold standard diagnostic tool. Once identified, the immediate intervention is strict impulse control. Clinicians deploy short-acting IV beta blockers, like esmolol, to forcibly lower the heart rate below 60 beats per minute and hold the systolic blood pressure tightly between 100 and 120 millimeters of mercury. This precise physiological control reduces the physical shear stress on the vessel wall, preventing a complete aortic rupture until definitive repair, typically a thoracic endovascular aortic repair, or TEVAR, can be performed. Directly anterior to the aorta, the heart itself is at risk. Direct sternal impact compresses the heart against the spine, violently bruising the myocardial tissue and causing a blunt myocardial injury. Clinical suspicion for cardiac contusion should rise when a patient exhibits unexplained tachycardia or hypotension that entirely resists standard fluid resuscitation. Confirming the diagnosis requires a specific trifecta: a 12-lead EKG showing new arrhythmias, blood tests revealing elevated troponin levels, and an echocardiogram showing the structural failure through abnormal wall motion and a dropping ejection fraction. Because the most lethal arrhythmias manifest early, management mandates 24-hour continuous telemetry monitoring. For severe myocardial dysfunction, blood pressure must be supported pharmacologically using inotropes like dobutamine to force the bruised heart muscle to pump. These vascular and cardiac disruptions deceive clinicians by mimicking standard hemorrhagic shock. Pouring IV fluids into a bruised, failing heart or a tearing aorta will not stabilize the patient. They require targeted hemodynamic manipulation. Beyond the vasculature, extreme kinetic energy also tears through the anatomical structures governing oxygen exchange: the trachea, the bronchi, and the lung parenchyma. A tracheobronchial injury presents rapidly. Air escaping from a torn airway forces its way into the surrounding tissues, causing profound respiratory distress and massive subcutaneous emphysema, a crackling sensation under the skin of the neck and chest. The major clinical red flag occurs during initial intervention. A chest tube may be perfectly placed, but the lung absolutely fails to re-expand, accompanied by a massive, persistent air leak bubbling through the drainage system. A CT scan of the chest provides a clear radiographic hallmark of a major airway tear. Bronchoscopy is the definitive tool here. It allows clinicians to visually locate the exact airway tear and guides the intubation of the unaffected mainstem bronchus, securing the airway prior to urgent surgical repair. While a torn airway demands immediate structural repair, a pulmonary contusion is a stealthy kinetic injury. The damage from the direct blunt impact progressively worsens over 24 to 48 hours. At the cellular level, the initial blunt force breaks the pulmonary capillaries. This causes a delayed capillary leakage into the alveoli, progressively drowning the lung tissue in its own fluid over a 48-hour period. Initial chest X-rays taken immediately after the trauma are deceptively clear. Over time, they develop patchy, non-segmental whiteouts that ignore lobar lines, mapping the exact impact zones rather than anatomical boundaries. The physiological consequence is documented on arterial blood gases. As the alveoli fill with fluid, oxygen cannot reach the blood, creating a worsening ventilation-perfusion mismatch and driving severe hypoxemia. Managing this creates a medical paradox. Clinicians must meticulously restrict IV fluids, keeping the patient on the dry side to prevent additional fluid from leaking into the bruised lungs, all without triggering hypovolemic shock. Severe cases demand aggressive pulmonary toilet and supplemental oxygen. When respiratory failure sets in, patients require positive pressure ventilation, either non-invasively through BiPAP or via full intubation. These airway and pulmonary injuries are insidious because their initial symptoms either perfectly mimic a standard pneumothorax or are delayed by hours. This diagnostic delay renders standard immediate trauma treatments entirely ineffective. The human thorax relies on critical protective boundaries to separate its sterile environment from the abdominal cavity. The two primary boundaries are the diaphragm and the esophageal tract. When blunt force hits the abdomen, the sudden pressure spike can rupture the diaphragm. This traumatic tear is predominantly a left-sided injury, simply because the dense mass of the liver physically shields the right hemidiaphragm, while the left remains vulnerable. Through that tear, abdominal organs are sucked upward. This herniation causes delayed dyspnea, chest discomfort, and allows clinicians to auscultate active bowel sounds directly inside the chest cavity. The definitive proof of a diaphragmatic tear appears on a CT scan. This is the collar sign, marking the exact anatomical constriction point where the herniated stomach or bowel is physically pinched by the torn edges of the diaphragm. Leaving the bowel trapped in the chest invites strangulation and necrosis. Management mandates a surgical laparotomy, approaching from the abdomen, to physically pull the organs back down and suture the diaphragmatic defect closed. The other vulnerable boundary is the esophagus. Though typically damaged by penetrating trauma, severe blunt force can rupture it, creating a lethal conduit for infection. It presents with a classic triad: chest trauma, severe pain, and sudden subcutaneous emphysema. Diagnosing this rupture requires a phased approach. Clinicians mandate a water-soluble gastrographin swallow study first to safely check for leaks tracking outward into the mediastinal space. They strictly avoid barium, which causes severe inflammation if it escapes into the chest. The immediate stakes are exceptionally high. The moment an esophageal tear is suspected, the patient is placed on strict NPO status and initiated on broad-spectrum IV antibiotics to stave off deadly mediastinitis. Antibiotics alone are not enough. The patient requires early surgical debridement, primary repair of the tissue, and wide drainage of the mediastinum within a strict 24-hour window to ensure survival. These boundary injuries are dangerous precisely because they blur the lines between thoracic and abdominal trauma. They mask lethal gastrointestinal complications behind standard respiratory symptoms, drawing clinical focus away from the true source of the failure. When we pull back from isolated anatomical regions and observe the stabilized trauma patient as a whole, a clear reality emerges. The secondary survey must be an active, systemic hunt. The overarching danger of the hidden six is their ability to disguise themselves. They hide seamlessly within the physiological noise and general chaos of multi-system trauma. Deploying precise physiological manipulation, like targeted impulse control or strict fluid restriction, acts as the crucial temporizing bridge to hold the patient together until surgery. Effective thoracic clearance requires systematic anticipation. By identifying the specific radiographic and physiological hallmarks of the hidden six, clinicians neutralize lethal threats before they manifest as overt physiological collapse.